Hey guys, Kirat Singh here. We're going to talk about how to template for a total hip. Whichever service you're on, make sure you talk to the attending about how they like to go through the specifics of templating. I'm going to go through something that I think works for my service and is something I've picked up from the other guys while I was a fellow here a couple of years ago now. The reason templating is important is it gives you a ballpark estimate, right? So if we template out a 58 cup and a size 6 stem, it gives me some direction in the operating room that when I'm reaming, I'm at a 54. I know that my destination isn't far off. And if I've templated a size 6 stem, if I start broaching into the 8.5, 9 or something like that, then I know, hey, I might have perforated or something has gone wrong. So it gives you some sort of parenthesis on either side, whether you're going too big or too little. It gives you a ballpark estimate of the sizes you need. It also lets you pick up an outlier. So if you have a super small patient and you're trying to template and you realize, wow, even the size 1 accolade isn't fitting, then you have enough time to preoperatively call somebody and say, hey, I might need a different type of stem. Also, the getting into the habit of templating is good because it lets you scrutinize your operative x-rays, your preoperative x-rays, and see, hey, is there hardware in the way? Do I need to get a screwdriver to take out some of these implants? Does this patient have sickle cell? And I'm going to need flexible reamers to open up the canal path and things like that. Also, it helps you look at the anatomy and say if you've got a protrusio hip where the socket is so deep that you might have to think about bone grafting or something like that, and to call for these adjuncts ahead of time. If you're working at a surgery center in the future, templating also helps you pull down your inventory. What you really need before, the things that you need to template are, one, you need an AP pelvis that's centered on the pubic symphysis, and the legs need to be rotated about 15 degrees internally because that'll bring the neck into profile, and it'll basically make the neck parallel to the cassette versus, if we naturally take an AP pelvis with somebody laying supine or even standing, they tend to have external rotation, and with anaversion built in, you're really not catching the true offset or the true neck shaft angle that is truly the case. Anyway, let's get into templating. On your desktop, you're going to have this GE PaxWeb application. On your desktop, here it is right here, GE PaxWeb. You can call 8help and they'll get it set up for you if you don't have it already. Log in with your N number and password. And then we've blacked out the names for patient privacy here, but you put your patient name, last name first. And here you'll see the x-ray that you need. Try and get the most recent x-rays because a lot can change even in a couple years. And so on the left side of the screen, I want to pick my AP pelvis. And down here, go to Ortho View and launch Ortho View. And here you don't need a password, you just log in. And if you're doing a total hip replacement, which is what we're doing, pick this up here. And if you're doing the left, click on the left. If you're doing the right, do the right. In this case, we'll do the left. If you're doing a resurfacing, you click down here. Add procedure. Come over here, you'll see the AP pelvis view, and then go down here and says start plan. Most magnifications If you set it to 120%, we've found that in the Emery system that works pretty well. So you set it to 120% magnification. And once that's done, let's get into templating. And the first thing I do is I look at the leg length discrepancy preoperatively. And so what you do is you take the transischial line wizard and click in this box. That'll pop up this line, and I drag that line down to the bottom of the ischial tuberosities on both sides. And various people do it differently. Some people run a line parallel from both teardrops. You could do that here too. I think the bottom of the ischial tuberosities is easier to see in this particular x-ray. And then you take these lines, and I'm just left clicking and dragging this line to the top of the lesser trochanter on both sides. And so once you do that, you have a sense of how does the left and right leg compare to one another. And if it's 0, then you know that there's no difference in leg length. And you can look down here in the left lower corner, and it says preoperative left leg shorter by approximately 0. So that gives you a sense of leg length discrepancy. It's not uncommon to have sizable leg length discrepancies with erosion of the femoral head and the socket in some patients. So then you come up here and click on template. And once you do that, the transischial line will disappear, the leg length line, but you can always put that back on by clicking up here and putting that line back on. I'm going to take it away because it's going to make it simpler to show you how to do the templating here. So let's start one by one. This box up here is for the cup right here. This box down here really helps you with your femoral component. So for now, I'm going to just click here and get rid of the femoral component. So if you look on the screen, the femoral component is gone. So now you can click in this box and pick the particular implant that you want a template for. In this case, we're going to go with the G7 cup. And if you can't find the cup in the recent templates up here in this section, then you just type in the particular type of cup that you want in this window here, and you can find the cup. Once you find it, you click on it, and then the way I do it is I take the cup and I pull it. I look at the inferior portion of the cup right here, and I can click just with the left button, and I can move the cup around wherever I want to. And so the way you do it is you go to the teardrop, and you want the inferior margin of your cup to be basically right up against that cup. Against that teardrop. And you want about 40 degrees of abduction. The way to change the abduction is I right click and then I drag, or you can right click and then you can swivel the abduction angle. And if you look at the degrees right along the edge of the cup, it'll show you what your abduction angle roughly is. So I shoot for about 40 degrees of abduction. And so once you've got the inferior edge of your cup along the teardrop, which is right here, and I watch the sort of inferior half of the cup go up against the ilioischial line, which is here, then I am okay with the position of that acetabular component. Okay. Now, how do you know whether you have a cup that is too large or too small? Well, let's exaggerate this and say if we had a size 48 cup, then clearly that is not really contacting any native bone. So you know that that's not going to be right. So I progressively increase the cup size until I get to an area, say 54. So that's not really abutting the teardrop there. I know I need to go larger. And so as you get into something like a 58 or a 60, that is abutting the teardrop, but you also want it to really contact host bone up top here. And so although that's contacting host bone, I know I'm going to end up reaming a little bit. And I want good host bone contact. And so at a 62, I know I've got good host bone contact all the way around, sort of zone 2 up through here and up along the lateral ilium. A little bit of overhang of the cup is perfectly okay. So once you have your cup in place, you see, well, that's a 62 size. This next column is for head size. Usually these days we're going with a 36 head ball, unless you have a patient that takes a super small acetabular shell. But a 36 head ball, or even larger, if you can get one in there, larger head ball equals more stability. And then over here, this is the liner. You have different types of liners, and we'll show them to you in the operating room. There are offset liners, there are face-changing liners, there are all different kinds of liners, but for the purposes of this tutorial, we're really just going with a neutral liner. So once we're done with that, then we have, for the purposes of this mental exercise, completed the acetabular part. Once you're done with the acetabulum, you move to the femur, okay? I'm going to, for the purposes of this video, remove the acetabular component for now, okay? And we're going to go down here and show the femoral component. Okay, again, you click on this box to pick the type of stem you want to use. I'm going to pick the Avenir Complete hip system. And here's how I start. I left click and I can move the stem in the Y plane. I can move it up or down. If I want to translate this stem, I have to click in these crosshairs. So I'm left clicking and I'm grabbing the entire stem and I'm able to move it in the X plane or the Y plane, however I want to do it. And so I start with a small stem. Okay. And it's just like putting a nail inside a femoral canal. How do you know that a nail is big enough? Well, when you have enough chatter of the reamer in the canal, then you know that you've got an appropriate size stem. So let's bring it over here. And what I'm watching is really, how is this stem contacting the cortex? And so if I end up putting this size stem in, and I want my sort of artificial hip and my artificial head ball to kind of approximate where the patient's previous natural bony head was, it's going to be about here. Then I ask myself, well, is that stem going to sit there, or is that stem going to end up sinking? Looking at that stem right now, it really doesn't have any good cortical contact anywhere. And I know that if I keep hitting this thing, just based on the space between the cortices and the metal, this stem is not going to be big enough. So let's go a little bit bigger. We can go with a size 5, and that's starting to get good contact with the cortices. Okay, these types of stems, and we can, in another video or in the operating room, go over the different types of stems, but this stem essentially is getting most of its grab to the host in the metaphyseal area, which is up here. And this is the most important part. And in the operating room, this is what we're watching for and saying, hey, is this stem grabbing the metaphysis, or are you able to rotate the stem to a point where it's really not grabbing any of the bone in this region up here? The diaphysis, this type of stem does not grab the diaphysis. The only reason I'm even paying attention to what's going on down here is I don't want to put a big, huge stem into a small canal and end up either cracking the stem or end up sticking the stem down into the diaphysis where it's getting stuck and is not grabbing up top. So that's called potting of a stem, where you basically have a stem that you broach for, and then it gets stuck right here in the proximal diaphysis and it's really grabbing on, but up here it doesn't have any stability. So as you grab the trunnion and you push it one way or another, you're noticing that, yeah, the stem's not going up or down, but it's certainly wiggling side to side, and that's a failure waiting to happen. So the punchline of what I'm trying to say is, when you try and template, pay attention to what's happening in the metaphysis, and yes, pay attention to the diaphysis, but the whole goal is not always to make sure that we have perfect end-to-end cortical contact side to side in this part. Because again, sometimes you can have a stem where you put it down in here and it'll get excellent metaphyseal grab, and you'll still have some space between the metal and the cortex down here, but still have a very stable stem. So anyway, what I do now is I say, well, if the native head ball is sitting, the center of it is about here, I want to have a artificial hip that's sitting at about that level. And so I ask myself, if I get a stem in to that level, will it have enough cortical contact to prevent further subsidence? And I think that a size 5 is probably appropriate for this femoral canal. Okay, so based on that, you have picked the size of your femoral stem, which is over here, size 5. There are other parameters that we're going to go over for a stem, but the size is basically the medial lateral dimension in most of these stems. So if you go to a size 8, obviously a size 8 is going to be bigger medial to lateral in the intramedullary portion. So we have a size 5 stem. Then we have to move to the next concept, which is offset. Okay, offset is down here. Offset is, the distance from the center of the head ball, the point of rotation. Because if you minimize yourself to be an atom, basically, and you are sitting in that center of the head ball position, you really shouldn't experience any translational motion. That's the center of the head ball. So that's the center of the ball, and the distance from the center of the ball all the way to the middle of the femoral canal is your offset. Okay, that's the offset. And obviously, the longer of a neck that you have, the higher the offset. Okay, if you end up putting an artificial hip in that has very high offset, what that does is the distance from the head ball all the way to the middle of the femur is a lot higher than perhaps the native offset. And what that does is that pushes your femur way lateral. And sometimes that has implications for irritation of your abductors and for troch bursitis and things like that. So you want to match their native offset. And the offset is really just a measurement from the center of rotation all the way to the femoral canal in the X plane. Okay, so the distance from about here all the way to about here. Okay, so stems come in different types. Usually they come in a standard offset, okay, which is something like this. So look at the screen. So that's standard offset or a high offset, and you see there's a lot more metal bridging the distance from the head ball to the stem itself in the high offset versus the standard offset. So standard offset is a stem that has less of a distance in the X dimension, meaning in the horizontal plane. Okay. So I say, well, are we going to go with a standard or a high offset? And I just look and see what the native head ball is doing relative to the native femoral canal. And so this is looking more to me like a high offset type of stem than it is a standard. Because if we put a standard offset stem in this one, which I guess you can argue to do, you may end up decreasing their offset as a whole. And this will make a little bit more sense once I bring the cup back in. Okay. Then so we've discussed the stem size, we've discussed the offset. The offset again is the distance in the X plane. And then let's talk about when we talk about head balls being +0 or -4 or +7 or whatever, pay attention to in the 0 position, okay, that's where the ball is going to sit on this trunnion. This is the trunnion, this is the ball. If we have a head ball that's a +7, notice how that head ball is sitting way higher up on the trunnion than a head ball that's a +0. So look at the screen again. That's a 0. That's a +7. Or if you want to start again at the 0 position, a minus head ball is going to sit further lower on the trunnion than anything higher than that, like a +0 or a +3.5. So once you've picked your stem size, you still have to pick stem offset, and then you have to pick, well, what kind of head ball am I going to put on this? Okay. So Now let's put everything back together. This is going to start to get a little busy, but let's reintroduce the socket, which is here now. And we've got our stem right there, okay? Now, this is sort of like a math equation. There are some fixed truths to think about this. Because a common question is going to be on the OITE is they'll show you a x-ray of a templated hip, and they'll say, what is happening to the leg length and the offset with this kind of template, okay? So here's how you have to think about it, okay? I'm going to get rid of the stem for a second. You have already picked a size 62 socket and you've put it in, okay? Just imagine a socket with the inner liner being in this place in space, okay? Then you have forgotten about this socket and you've moved to the stem. And I'm going to get rid of the socket and I'm going to show you the stem, okay? And so then you have templated the stem and the native head ball is gone, okay? And the native neck is gone and you just have this metal trunnion with a trial head ball sticking on it, okay? So you have that, and then you have your socket, okay? You have to get this ball back into the center of this socket, okay? And you understand that physically how to do that, right? When you're in the ER, you have somebody with a dislocated hip, you have to get the ball to sit back center in the socket, okay? How you do that on a template is you just picture, well, what's the center of the socket, okay? The center of the socket is this spot right here. This is the center of the socket, okay? Then you ask yourself, well, when I get this reduced, the center of the head ball is going to move into the same point as the center of the socket. That is when the hip will be reduced, okay? Where we have it templated right now, that is not a reduced view of the hip. That is you looking at the socket and saying, I put a socket in, and then you templated the stem and you put a stem in. But to get the reduction mentally, you have to do a mental exercise in which you say, oh, the center point of the socket, which is over here, has to match the center point of the head ball. And therefore, you will then at that point have a reduction, okay? So now let's go through a mental exercise, okay? Let's say that I put a size 8 stem in, which really wouldn't even work. The way it would work is I would try and impact it in, and you'd only really get it to about that depth. So that much of the stem is hanging out, okay? So you have put in the socket in this position, and you have put in the stem in this position, okay? And the OITE will then ask you what is going to happen to the leg length in this scenario. I'll give you a second to think about it. Right? You have to do the mental exercise of getting this ball into this socket. Okay? You can't change anything because you have already bought this stem, you've already bought this head ball, and now you just have to get this ball into this socket. Well, to do that, just remember, the center of rotation of this ball, which is here, has to sit right on top of this center of the socket, okay? If you do that, you're going to have to really pull this leg out to get the ball in, okay? And the lesser troche is now then going to sit way down here compared to this lesser troche, and you have effectively really lengthened this patient, okay? The converse is true. Let me do it another way. Let's say you really undersize this stem, okay? So instead of a size 8, we pick a size 2 or something, or even a 3. Let's pick a size 3 for the purposes of this exercise. And we really screwed this hip up. We've cut the lesser troche off, which is a separate complication in and of itself. Nonetheless, for the purposes of this, say this is where you have got the stem to sit, okay? And you've already set up your socket up here. It's already stuck inside the native acetabulum. You are done with the socket portion of your surgery, and you move over here, and this is where you have now set up your stem. Okay, come time to reduce this, and then you reduce it, and you get this ball to sit in this socket. Effectively, what you've done is to get this ball into this socket, this whole femur needs to translate proximally, and you have shortened the patient by doing that. So understand leg length as a movement in the Y plane, right? If my templated hip sits way more inferior, the head ball sits way more inferior to where I have already agreed to put the socket, then you know that when you reduce this thing, this is going to be really short, okay? If, however, I put if I put a stem way higher than the native head ball, and this is where I say, okay, well, this is where I want to put my stem, and that stem wouldn't sit there because it's too small, but say you really oversize it and again went to like a size 7. Then when you go to reduce it in the operating room and you pull length, you're going to have to pull and pull to get this ball into the socket. The whole premise of all this discussion is the acetabular component is fixed. Okay, you have to accept that part of this equation and say the socket is fixed. What is it going to take to get the ball into that socket? In this case, it's going to take a lot of me pulling on that leg to get that in, and you're going to end up lengthening it. Okay. Again, one last time, if you have a super undersized small stem and I have subsided the stem in that low, which is way inaccurate and is really just for the purposes of this exercise, then you know that this head ball is easily going to fall into this socket, but what you've done is compared to what the length of the femur was before all this, you have really shortened this patient. So that is leg length in the Y plane, okay? Now, once you understand leg length, the same is true for the offset, right? So if we have a head ball that is sitting in the socket like that, this is our templated stem and our templated socket, then in your mind's eye, all you have to do is say, what's going to happen when the center of the head ball sits in the center of the socket? Okay, so let me give some exaggerated examples. Okay, so let me give you a high offset stem. Let me give you a really large high offset stem. Okay, let's go, for example, with a size 9. Okay, and let's say the center of the head ball is sitting right here where my cursor is. The white cursor is sitting right there. That is the center of my head ball. Okay. Now, remember, the center of my socket is over here. Okay. Just ignore the stem and anything on the femoral side right now. And let's begin this equation with here's the socket and here is the center of my socket where the white cursor sits. Okay. So we've put the socket in, we've agreed, we've bought the socket in that position. Okay, now let's go to the femur. We've put this femoral stem in. We've decided, hey, we're going to go with a high offset stem. Okay, and the head ball is now sitting in this position. Okay, now if you're the resident with me and I say, okay, let's reduce this hip, you have to get this center of this head ball into the center of this socket. Okay. When you do that, you effectively, what you're going to have to do is you're going to have to really pull to get this ball sitting in this socket over here. Okay? You are going to have to really lateralize the native femur. And what you've done is you've done a disservice to the patient. You've lateralized them further than they need to be. Okay? Again, when you see a template, you have to ask yourself, okay, the acetabulum is fixed. What is the center of rotation of the acetabulum? Okay, it's the center point here. Okay, good. Now, what is the center point of my femur? Okay, the center point of your femur is the center point of the ball, which is over here, right there. Okay, great. Until that point, you have not actually carried out a reduction. Okay, So you carry out a reduction. The reduction is when the center point of the ball meets the center point of the socket. And when you do that, what's going to happen to the native femur? It's going to go where you ended up moving it because you had to get the ball in the center of the socket. And it's not going to really like that because it was used to sitting in a position a certain distance from the ischium. And when you end up putting the ball with a high offset stem in a position that then when you reduce it ends up lateralizing the femur, you're going to push this femur way out further lateral, and it's going to cause irritation of the troch bursa and the abductor complex. Okay, let me give you another example. Let's go through one more example. If we pick a stem, a small stem with a standard offset, okay, and I end up putting it, and again, for cursor purposes, you just left click on the stem and you can pull it up or down like this. If you want to rotate it, you right click on the stem and you can swivel it like this, okay. And if you want to translate and move this whole thing around, you basically go to the center point of the cursor and you can move this whole thing around however you want like that. Okay. So now, say this is how I end up picking the template. Okay. So again, let's go through the exercise. The acetabular component is fixed in space. It has a center point, which is here. Okay. Then you have already broached and put in this femoral component. Forget all the native bone right here. This is all gone. All you have is this head ball that needs to go into the center of this socket, okay? Well, the center of this socket, the center of this ball is going to go to the center of this socket. What that effectively does is it'll push the femur more medial, in a more medial position than where it was before we ever as surgeons got involved. And so you've decreased their offset, which is not ideal from a biomechanical standpoint, okay? So ultimately, think of leg length in the Y-plane, right? If I've stuck a stem way up here, and I say, what's going to happen when you reduce this? Well, you're going to really lengthen somebody if you end up with a femur that is templated out like this, assuming that it actually grabs the stem. If you template them like this, and you go to reduce it, when the ball sits in the socket, you have basically shortened their leg big time, okay? If in the X-plane you template them out where the center of the head ball sits lateral to the native socket, well, the ball has to go home to the center of the socket. And when it goes home, if it has to go medial, guess what? You've medialized the native femur. And if you've templated in a position where the head ball is sitting more medial to the center of the socket, then guess what? When that ball goes home, it's going to drag the entire femur further out lateral, and when that happens, you're going to really increase their offset and create issues, especially in thin patients where the troch is going to irritate their lateral proximal thigh. Okay, so once you've got the appropriate stems picked out, in this case, I decided on a size 5, a 36 head ball, and a high offset stem. You get it back. I'm going to right click right over the 4-point cursor, pull it back into the femoral canal, and I know that based on this, I want you to think about this for a second. If I show you this template and I said, this is how I've ended up templating this, what's going to happen? Well, the socket, I've already bought the socket, okay? The center of the socket is right here, and the center of the head ball is right above it, give or take, okay? So when that head ball goes home, meaning when I reduce the hip, when the ball goes home to sit in the center of that socket, the ball is going to end up having to go inferior, okay? And when that happens, it's going to drag the entire femur further distal. So what do I need to do? Well, I don't like how that's going to lengthen the leg, so I'm going to give it. I've got a couple different options. One, I can sink the stem in a little bit more, and that can help. And that for me probably is acceptable. Right about there, give or take. Okay, and that cut is going to be pretty much right along, almost gives me maybe a millimeter or two above the lesser trochanter, and that's gotten it pretty close. But now when I see what the center of the head ball is doing with respect to the center of the acetabulum, I know that my leg length and offset is perfect compared to the pre-op. So you want the center of your socket and the center of your head ball to match up perfectly. If they don't, then you have to do a mental exercise in your head that says, well, when I get the head ball reduced in the socket, that may change my leg length and offset. But you may want to do that because if I have a patient that is 5 millimeters short preoperatively, I will probably want to template them where the head ball sits 5 millimeters high relative to the center of the socket, because when I go to reduce the ball into the socket, I'm going to gain 5 millimeters of length. So once you have your components picked out, click this T up here, click anywhere in this x-ray, and once this text appears, you click on the text, go to annotation, and delete whatever's in the box. I end up putting the socket size, so that's a 62 with a 36 head ball, a 5 stem with, we ended up doing high offset, and then a plus, or we ended up picking a -4 head ball in this case. Okay, and then if you had a pre-op leg length discrepancy, you put pre-op leg length discrepancy. In our case, it was 0, so we're going to put that there. And then you click on this, you hit font. You want a large font that you can see up on the screen when these x-rays are up in the OR, and you do that. I double check everything. So 62 cup, correct, 36, 5 high offset with a -4 head ball. Pre-op leg length was 0. Again, I look at the position of the socket. It's inferior margin up against the teardrop. The sort of superior, middle to superior edge of the cup has excellent bone contact all the way around. A little bit of overhang is acceptable. So I like that cup position. It's about 40 degrees of abduction. And you can look down here. It'll even tell you 42.1 of inclination of the cup. I like the cup position. I look over here at the stem size. I know that it's got good cortical contact through the proximal diaphysis, so it may pot, unlikely, but it's got good close cortical contact through here. It's got good metaphyseal fill, and then the center point of the socket and the center point of the head ball, I just look at it and I look at the XY dimensions and I know that the leg length offset is going to be appropriate. Once you have that, then you can click Save, and you don't leave this screen until you see this next window pop up where it'll send the exam to PACS. And once that's done, you can double check, go into PACS and see that your templated x-rays are there. Again, we're all 5 of us are here to answer questions in any way we can. I encourage you, the accuracy of templating is only going to go up with more templating that you do. So I encourage you guys to really pull this stuff up and work with it as much as you can. Thanks.